Well, thank you so much for having me. And I thank Dr. Sullivan for that really nice review. She gave you a lot of information, so it makes my job a lot easier. I can skip through a lot of the basics and move on to the specifics about Lewy body. So tonight you've already learned a lot about FTD. And as Dr. Sullivan highlighted, we oftentimes like to group dementias based on the underlying pathology. So we talked a lot about FTD and the complexity of the neuropathology there. We also talked about Alzheimer's disease and past dialogues in dementia. But today we're going to take a few steps over and we're going to focus on Lewy body dementia, which, as you can see from the box, is oftentimes closely related to Parkinson's disease dementia. So what I plan to talk about today is, first, I just want to provide an overview of the clinical features. We'll briefly review the neuropathological features. We'll talk about some available pharmacological treatments, and then move on to some behavioral management strategies. So DLB is actually a fairly new diagnosis. Of course, cases of DLB have been around for a long time, and there have been many medical reports written about them. But it actually wasn't until 1996 that there was a formal consensus that met and established formal guidelines. So this is pretty unique. This is probably a diagnosis that's really been formalized in all of our lifetimes. Despite the fact that we've only been able to fully put a name to all of these symptoms very recently, it's actually estimated to be the second most common form of dementia in older adults, so those that are 65 years and older. And it's estimated from population-based studies that dementia with Lewy bodies is at about a 5% of the total dementia cases in the population. And this actually stands out quite a bit from the research that the neuropathologists do. So when after death and the scientists are looking at the brains, they actually find that Lewy bodies, the pathology that underlies this disease, is present in about 16 to 25% of individuals. And I think this discrepancy between what we see in the population and what we see in these postmortem studies really highlights the diagnostic challenge with this disease. There's a lot of heterogeneity in how this disease presents. So just keep that in mind as we go through the clinical features. And as I mentioned, it's a disease that typically affects older adults, so average age range is between 60 and 80, but of course there are exceptions beyond this. So these are the criteria that are necessary for a possible diagnosis of dementia with Lewy bodies. So of course there does have to be dementia present, and then there's a requirement of having 2 or more of the following core features. So either fluctuating cognition, visual hallucinations, Parkinsonism, or REM sleep behavior disorder. And I'll go into all of these with just a little bit more detail. So clearly with the name, dementia with Lewy bodies, dementia is very core to the presentation. So in this case, we're talking about a progressive and gradual cognitive decline that happens that eventually becomes severe enough to interfere with normal daily activities, so perhaps more difficulties driving or managing finances. And when we think of dementia, Dr. Sullivan did a great job of really highlighting that there's a lot of different forms of dementia. And Alzheimer's disease is by and far the most prevalent of those. So I think a lot of us, when we think of dementia, we kind of think of someone with Alzheimer's disease with that really dense amnesia, difficulty remembering information, asking repetitive questions. And actually, the presentation in dementia with Lewy bodies can be quite different. So in a pure dementia with Lewy bodies, memory is actually spared initially, as well as naming, but where you see more difficulties manifest is in attention and executive function and in visuospatial abilities. So attentional difficulties might manifest by difficulties watching television, being able to follow the plot line, or you might notice more thought lapses during conversations. Executive function sort of refers to all of those higher level cognitive skills like planning and organizing. So you might realize that the individual is no longer keeping their desk and papers as organized as they used to. They might have difficulties multitasking. This can manifest when driving, so having a hard time listening to the GPS and understanding the directions, and also being able to attend to the road. And we can also see visuospatial difficulties, and these oftentimes emerge early in the disease course. In the clinic, we test them by showing pictures and then also having people draw objects. So here you can see these renderings by an individual with dementia with Lewy bodies, and they're attempting to construct a three-dimensional cube. And you can see that the perception and ability to do that isn't quite there anymore. And this will manifest by difficulties perhaps getting lost or difficulty finding the car in the parking lot, those types of issues. So the next symptom that we're going to talk about is fluctuating cognition. And this one is actually fairly complicated to assess clinically because we all have fluctuations. We all have fluctuations in how well we think that we're attending to information and processing information. And certainly patients with Alzheimer's disease do show fluctuations. But when we refer to fluctuating cognition in dementia with Lewy bodies, we're really referring to more than that. We're referring to episodes of perhaps incoherent speech, severe daytime lethargy, so perhaps a tendency to fall asleep very easily when seated in a chair or not engaged in activity, zoning out or staring into space. And the next symptom is visual hallucinations. So visual hallucinations are very common in dementia with Lewy bodies. It's estimated that they occur in about 80% of individuals with DLB. It's important to note visual hallucinations do happen with other forms of dementia. So it's estimated that about 25% of individuals with Alzheimer's disease might experience visual hallucinations. But in diseases like Alzheimer's disease, the hallucinations tend to occur much later when the disease is more progressed. Whereas with dementia with Lewy body, the hallucinations tend to occur much earlier. These hallucinations are oftentimes very well formed, so the person will see something not just out of the periphery of their eye, but very clearly. They're oftentimes described as opaque and solid rather than transparent, and they tend to be recurrent, so people tend to see the same things over and over again. Most frequently, the reports are of people or of animals. So someone might report seeing a little girl near the television or elves in the backyard, tigers in the bedroom. And these seem very, very real to the individual. Individuals with DLB tend to have varied insight, so it's estimated that about a third of individuals with DLB do have some insight, but oftentimes this diminishes as the disease progresses. And it's important to note, sometimes they have insight when they're talking about it or maybe in a doctor's office, but in the moment, in that experience of distress, it might be really hard to disengage from that visual hallucination and process that it's not actually real. And the emotional responses to these vary. Oftentimes, the hallucinations aren't in and of themselves distressing in terms of having a very violent hallucination. Occasionally they are. But about 50% of individuals describe them as very distressing. And it's important to note the visual hallucinations, when they occur, they tend to cluster with other behavioral symptoms. So you tend to see hallucinations in the context where there's oftentimes a lot of disturbance in sleep and a lot of apathy and anxiety too, so it tends to kind of group together a little bit. Third is Parkinsonian features. So this is a pretty common group of symptoms. It occurs in about 85% of individuals with DLB, and this is one of the things that makes the diagnosis so tricky, is we want to look towards something that we know is always going to be the case. We're always going to see these motor changes. Not always true, but most of the time it is. So when we're talking about Parkinsonian features, we're talking about three kind of primary symptoms. One of the genes is the SNCA gene, and this is the gene that is actually responsible for coding the protein, the alpha-synuclein, which is the neuropathological protein that is deposited in the brain in dementia with Lewy bodies. The other is a GBA gene, and this gene helps regulate lysosomal activity. So the lysosomes are kind of thought as the house cleaners of the cell. They kind of clear out toxins and debris and damaged parts of old cells. And this has also been linked to increased risk. And then ApoE is involved in lipid metabolism and transport. It's also the gene that's been very strongly implicated in Alzheimer's disease. And there's some evidence that having the E4 allele also increases risk of dementia with Lewy bodies. So neuropathology, we touched on this a little bit. So the core neuropathological feature is the accumulation of alpha-synuclein in the brain. Alpha-synuclein, it's a protein, it's found in the brain, it's also found in other parts of the body. There's a lot of alpha-synuclein in the GI system. This is thought to be one of the reasons why constipation can be an early symptom. And alpha-synuclein, we don't totally understand what it does in the healthy brain. It's oftentimes found on the presynaptic terminals of the neurons, so the areas that typically release the neurotransmitter to communicate with the other cells. So it's thought that they have some role there. And in dementia with Lewy bodies, there tends to be a misfolding of the protein, and so they actually form aggregates or clumps. And as you can see from the picture, there's kind of a typical progression. So typically they start at the brainstem, move up to the midbrain and the limbic regions, and then go throughout the cortex. It's an area of active research to understand how and why these proteins become dispersed around the brain. There's some research that suggests that there's some type of cellular transmission, but basic scientists are still kind of working hard to understand what's the reason for this spread across the brain. It's important to note that a lot of dementia with Lewy body cases, they oftentimes have other pathology. In particular, about 80% of the cases also have amyloid beta, which is the protein, one of the proteins that's abnormal in Alzheimer's disease. And it's thought that they might have some type of interactive effect, that they each make each other worse. So that's another area of ongoing research. And it's thought that this amyloid deposition might also lead to some of the memory difficulties with dementia with Lewy bodies that you can see in some cases. So how do we detect it? So we have the clinical symptoms, which we look for, and we can also get a little bit more evidence with imaging. Imaging in and of itself is not purely diagnostic. Again, these are things that tell us that it's probably more likely to be this disorder versus the other, but they're not 100% definitive. So one of the scans that's often done is a DAT scan. So this is where a radio tracer is injected that binds to dopamine. And there tends to be a lot of dopamine receptors in the striatum. So that's those areas that look like a comma of the caudate and the putamen. They're really important for motor movement. And as you can see in the normal individual, those areas are really nice and bright. So you can see that there's a lot of binding in those areas. And it's actually pretty well preserved in the individual with Alzheimer's disease too. But when we look at the individual with dementia with Lewy bodies, we see diminished response. So this scan can be pretty helpful from differentiating against an Alzheimer's disease form of dementia. It has about a 75% accuracy rate. The one limitation is it doesn't distinguish between other types of diseases that also have diminished dopamine. So people with Parkinson's disease or progressive supranuclear palsy or multiple systems atrophy, other types of disorders will also display this diminished dopamine uptake. Another scan that can be helpful is the FGG PET. And so that's where we're actually looking at glucose metabolism in the brain. And you can tell by this scale that that red color that shows a lot of glucose metabolism, so we assume that is associated with a lot of activity. And here the normal control brain has a lot of that red color showing a lot of activity. But what you can see with the individual with dementia with Lewy bodies is that really the posterior area of the brain, the occipital cortex, is where you see the hypometabolism early on. And so this is the area of the brain that's really important for vision. And there's thought that these hypometabolism in the occipital lobes is one of the reasons that visual hallucinations is such a core feature in this disorder. And as you can see, the pattern does vary from that of Alzheimer's disease, where actually the occipital lobe tends to be a little more preserved relative to other regions. So pharmacological treatment. So this is an article put forth from The Lancet in 2015. And as you can see, we have a lot of symptoms that emerge with dementia with Lewy bodies and a long list of treatments. And they're rated on their level of evidence in the research. How convinced are we based on the available research that this is helpful? And unfortunately, you'll see that there's not a lot of strong evidence for a lot of the medications listed. The one that is given the actual label of being helpful is actually the acetylcholinesterase inhibitors. So these are things like Aricept or Exelon. They're oftentimes given to patients with Alzheimer's disease too, and they are thought to increase the amount of acetylcholine, which is a neurotransmitter that's really important for memory. And it has been shown that when given to patients with DLB, that it does help stabilize the symptoms for a little bit longer, but it's important to remember it's not curative, and it won't stop the eventual progression of the disease. So we talked that DLB has a lot of symptoms. I'm just going to briefly highlight these in the red box because these are our more behavioral symptoms. So things like hallucinations, depression and anxiety, REM sleep behavior disturbance, excessive daytime sleepiness. And I highlight these because they are really important, more so than the cognitive symptoms. Most family members, most individuals with DLB find these symptoms to be the most distressing and the hardest ones to live with. And additionally, we have research too showing that not the cognitive symptoms, but the behavioral symptoms are most strongly related to early nursing home placement. So in order to keep people safe and able to live at home for as long as possible and function in the environments they want to be in, we really need to address these symptoms. And unfortunately, we don't have a lot of pharmacological treatments, but I will review some of our behavioral treatments. So one question to ask is, why don't we just use antipsychotics? We have other medications that treat hallucinations and other disorders like schizophrenia. And the reason that they're not recommended is not because they're not helpful, but because they're associated with a lot of side effects. So one, these medications tend to deplete dopamine, and you recall from the picture of the DAT scan, that's already depleted typically, so it can really worsen the motor symptoms and increase risk of falls and hospitalization. Also, as reviewed, people with dementia with Lewy bodies might have extra sensitivity to these medications, so they can really lead to a lot of confusion and sedation. And then, like in all forms of dementia, they can increase risk of mortality. So it's recommended that these not be used as the first line of treatment. There are times when the risk of the behavior might outweigh the potential risk of the disease, so it's something that has to be managed on a case-by-case basis. But behavioral strategies are recommended first. And because I don't have time to talk about all the behavioral strategies and all the symptoms, I'm just going to focus on one. I'm going to focus just on the visual hallucinations. And so we'll talk about strategies, and I've grouped them into three categories. So preventative, those are the strategies that are geared towards trying to reduce the frequency of the hallucinations. Then we have action-oriented strategies. So these are things that can be done in the midst of a hallucination. They do take oftentimes some cognitive control, so they may not be so appropriate for those with more advanced dementia. And then finally, distress management, which is oftentimes more delivered on the part of the family and the caregivers. So as I mentioned, preventative strategies are anything that is going to try to reduce the frequency. So one, there are a class of medications that have anticholinergic properties, so they deplete the acetylcholine in the brain, which we know is important for memory, and they can also make hallucinations worse. Drugs with these properties fall under a broad range of classes, and often it has to do with how many of these drugs you're on, what is the dose. So if your loved one is experiencing visual hallucinations, it's worth having that discussion with your doctor. Are there many anticholinergic medications, and can we switch for a medication that has less of an anticholinergic load? The others are strategies that are used to modify the environment. So there's a lot of research suggests that it's actually, some people might have hallucinations because of misinterpretation of actual visual stimuli due to low lighting conditions or not being able to see that well. Then the thought is that the brain is here, it's trying to make sense of the surroundings, so when things can't be seen correctly, it might actually make something up that doesn't really make too much sense. So recommendations can be to increase the lighting in the room, obtain an eye evaluation and treat vision loss, remove cataracts, and then perhaps cover mirrors because they kind of give off reflections that can be misinterpreted. The second are action-oriented. So these are things that are done to reduce perhaps the intensity or the distress associated with the hallucination. So one of these strategies, as we mentioned, taps into the environmental factors. So low lighting is a risk factor for hallucinations. So some people find that by turning the lights on, that kind of reduces the intensity. The other is to blink hard or to close eyes. About 40% of people with dementia with Lewy bodies say that the hallucinations persist with the eyes closed, but about 60% say they don't. So typically, if people have more awareness, they might try blinking their eyes really hard to see if that helps with the hallucination. And then the other involves kind of reality testing. Again, this is more appropriate for people with more insight. But oftentimes these hallucinations are really only in the visual modality. So in order to test the perception of realness, you can try to do things like, can you touch the hallucinate or the image? Can you hear it? Things that sort of give you some more evidence that this is actually, not something real. This is just my brain playing tricks on me. And then finally is distress management. And this is a big one. So we know that caregivers and family responses can have a huge impact on behavior. I think anybody with children is probably very familiar with this concept. So if a child falls and the parents act all distressed and upset, usually the emotional reaction from the child is very large. Whereas if the parents just kind of provide some reassurance and tell them that they're okay, usually that emotional response is much more dampened. And we want to use that same strategy too. We want to try, even if we can't make the hallucinations go away, we want to make them as least distressing as possible. And those techniques involve, one, really focusing on your nonverbal cues. Oftentimes in dementia with Lewy bodies and all forms of dementia, it becomes harder to process and attend to language, especially during times of distress. So keeping the posture tone, keeping the face very pleasant and relaxed, voice tone calm can be helpful. The second big tip is to avoid arguing. It's really hard when the person is telling you there's a tiger or a little girl in the room and you don't see them to kind of go along with it. But if that's the person's reality, sometimes it just makes them more upset that arguing. I saw one patient who had a lot of hallucinations of snakes, and he would get really upset when his wife would argue with him, not only because she was arguing, he was defensive, but also he was concerned about her safety. He didn't want her to get hurt, so he became even more ardent in his attempts to really convince her that no, there was a snake. So the recommendation is that instead of arguing, you want to provide reassurance, and you want to kind of empathize with the feeling and tell the individual, don't worry, I'm going to take that load for you, I'm going to take care of it. There's a little girl on the floor, there shouldn't be a little girl on the floor, don't worry, I'll get her out of here. And then if you can, try to escort the person to the other room to kind of get their attention on something else. So I know we're out of time. This was a lot of information in a short amount of time, but I do have some resources too that you can go to if you're interested in learning more.